So I want to acknowledge that I am grateful that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And each of you is similarly on a territory where you are in the province. And I would again ask everyone to reflect on where you are and grateful for the land that is here. Next slide. So we're fortunate today to have a presentation from Dr. Michelle Wong, who's a practicing nephrologist and a Michael Smith scholar. She's practiced at the University of British Columbia and in the Lower Mainland, and Dani Renouf, who's the chair of the Provincial Dietitians Committee. So they're going to speak with us today about nutrition outcomes in non-dialysis CKD patients in British Columbia. And it's really a great pleasure to see and hear about what we're doing, how we're doing it, and how we're reflecting on it. So with that, I'll pass it over to Dr. Wong and Dani.
All right. So welcome and good morning. And today I'm going to be talking about our research program in renal nutrition that represents a collaboration between nephrologists and dietitians. Today we're going to focus on the nutritional status and outcomes in non-dialysis adult CKD patients to demonstrate how we move from policy to practice to research. Now first, a bit about me. I recently completed my MPH at the Harvard T.H. Chan School of Public Health, but I first developed an interest in nutrition research through a dialysis fellowship at the Renal Research Institute in New York. As Adair mentioned, I'm currently funded by the Michael Smith Foundation for Health Research, and I'm currently an advisor for the Foundations of Scholarship course in the UBC MD undergraduate program. And in this role, I help students plan their scholarly projects. And I'm also part of the inaugural cohort of the ISN Emerging Leaders program. And in this program, we have an opportunity to work on collaborative public health projects, but also this program helps us to work towards achieving our leadership goals. And my focus is to improve collaborations in research between nephrologists and allied health. So first, a bit of a background on the topic. I want to introduce two concepts. The first is malnutrition, which actually refers to undernutrition. And this represents predominantly a loss of fat mass. And this is a consequence of insufficient nutrient intake. And this contrasts with protein energy wasting, which represents a loss of both body protein stores and fat mass. And it's influenced not only by nutrient intake, but also inflammation, metabolic derangements, and comorbidities. And this is the central key area that we're focusing on in chronic kidney disease. So this slide here shows the complex interactions and consequences of protein energy wasting in chronic kidney disease. So we see in the gray boxes above all the causes of protein energy wasting, the metabolic derangements, comorbidities, and this uremic milieu that leads to protein energy wasting. And many of these factors are related to inflammation. And in the green boxes below, you see the many consequences of protein energy wasting. And this includes increased mortality, hospitalizations, decreased quality of life, increased risk of cardiovascular disease, and infections. So in terms of the scope of the problem, the prevalence of protein energy wasting among non-dialysis CKD patients is about 11 to 54%. And this is based from recent systematic review. Only 5 studies were included in the non-dialysis CKD population, and these studies had significant heterogeneity. And as shown by the graph here, we know that weight and therefore BMI declines significantly after the eGFR decreases to less than 35. And this was demonstrated in large cohort studies, the CRIC study and the ASK study. So it's important to study protein energy wasting in non-dialysis CKD because first of all, we know that early mortality is or after dialysis initiation is very high, particularly in the first 120 days after dialysis initiation. And this is shown in the bar graph at the top right using DOPS data. And we know that malnutrition and hypoalbuminemia are potentially modifiable determinants of this mortality. Patients with more than 5% weight loss before dialysis initiation have a much higher risk of death after starting dialysis compared to patients who have stable weight. And secondly, we know that nutritional status is lowest at dialysis initiation. And this is demonstrated by the bottom graph based on previous research that I have done using Fresenius North America data. And thirdly, with the focus on preemptive transplant, we know that nutritional status could impact wound healing and post-transplant outcomes. Therefore, it's important to study interventions in the non-dialysis stage. And so how do we assess nutritional status? There is no single measurement that provides a complete assessment of nutritional status. There are many caveats to interpreting serum chemistry markers because many of them are influenced by non-nutritional factors as well. So we have four main categories here: serum chemistry, dietary intake, body mass, and body composition. There is a wide spectrum with regards to ease of data capture, with serum chemistry being very easily captured in our PROMIS database, to body composition markers, which are require technical measurements and they're not routinely used in practice. There are also nutritional scores that use a combination of these parameters, and the most commonly used ones are the subjective global assessment, and in the CKD population and the dialysis population, there's a malnutrition inflammation score. So consensus criteria have been developed for protein energy wasting diagnosis, and it uses these four main categories of parameters here: serum chemistry, dietary intake, body mass, and muscle mass. And an individual would need to meet at least one criterion out of 3 out of 4 categories in order to be diagnosed with protein energy wasting. So most evidence for oral nutritional supplement use is from the dialysis population. And while studies have demonstrated benefit in biochemical, weight, and body composition parameters, the effect on hard outcomes such as mortality and hospitalizations, as well as patient-reported outcomes such as quality of life, have not been well established due to underpowered RCTs. I do note that there was one large RCT that was presented as a late-breaking trial at last year's ASN, still yet to be published as far as I know. They looked at an intensive oral nutritional supplement protocol in which they gave ONS to everyone in the dialysis unit regardless of albumin versus the conventional protocol, but they did not find a difference in mortality. However, there have been previous mortality studies and there did suggest a benefit in large observational studies. So the evidence for ONS use in protein energy wasting among non-dialysis CKD patients is lacking. Basically, there is one RCT that looked at oral nutritional supplements on top of a low protein diet to look at kidney function outcomes. However, they did not select patients with protein energy wasting. And so due to the lack of studies in non-dialysis CKD for treatment of protein energy wasting, this formed the basis for launching the program of research at BC Renal in collaboration with the BC Renal Dietitians Committee. And I'm going to pass it over to Dani to discuss more about this group and the nutritional supplement policy.
Thank you so much, Michelle. Thank you, Adira. Thank you, BC Renal and my team of provincial dietitians for all your support with this project. My name is Dani Renouf. I'm the renal resource dietitian and sit as chair of the BC Renal Dietitians Committee. I have over 15 years of experience working in clinical dietetics. Most of my time has been spent working at St. Paul's, and currently I work in the kidney care program at St. Paul's, as well as do administrative duties related to BC Renal. I received my Master of Science in Healthcare and Epidemiology from the University of British Columbia a number of years ago, and so it's a real pleasure to be able to engage in this kind of dynamic and relevant research with Michelle and our team. So I guess I'll just move on to the next slide. I have this great opportunity today to share with you what our renal practice group does, and that's what RPG stands for. And so we have an open membership. We have over 90 dietitians province-wide working renal care that join our relatively monthly meetings to discuss relevant topics to clinical practice, and so on, and I'll go into the details of kind of what our structure is like. I'm the primary liaison, so as part of my role, I sit on other committees with whom I collaborate. For example, the Kidney Care Committee, the Pharmacy and Formulary Committee, as well as I liaise with Promise on relevant factors related to our nutritional supplement program in particular. We have representation from each health authority in our committee, and we do rotate chair and secretary responsibilities because we don't currently have capacity for an administrative support person. We are involved in quite a number of projects, mainly done from the side of people's desks. So there's a lot of commitment to helping ensure optimal patient care through these committees, which include a lot of patient-centered programs and projects. So the key contributions that have helped BC Renal's nutrition arm succeed as well as it has over the years has really been the dedication to our patient education materials. And more recently, we have increased our social media capacity to do nutrition videos, educational videos for patients, so that we're capitalizing on the virtual platform for learning. Also, we obviously have the privilege of the nutritional supplement policy. And this policy was created a number of years ago. We've updated it over the years, and I'll go into detail of what that entails, but it's a huge benefit and a unique feature of BC Renal and the dietitians' work over the years. We also participate collaboratively on standards of practice, algorithms, and clinical documents with other committees in BC Renal. And of course, now we've added this incredible opportunity to be engaged in valuable research. Really, my goal, and I think the goal of most of the committee's work, is to align and essentially bring together best practice standards, bring together the discussions that are held at the level of the Pharmacy and Formulary Committee to work along with Promise to implement the nutritional supplement policy features and to provide frontline education to patients, provide resources, and finally to bring that all together to align with the BC Renal strategic plan. So some of the goals of our renal practice group are to essentially create alignment, as I mentioned, with BC Renal strategic plan, the education and clinical Promise, to form research partnerships, to continue to offer best practice standards, to really look at funding allocation as well, which this particular research project has alluded requires more exploration, to ensure that there's equality and egalitarian care across the province in terms of nutrition, and also to ensure that we're collaborating with respective committees on specific care issues relevant to each of the modalities in renal. The Pharmacy and Formulary Committee is a huge part of my work because the nutritional supplement program receives review and approval through that committee. And so it's been actually a great opportunity to align our formulary a little bit better for economic reasons as well as for patient needs as a result of this research. And now we're looking at post-kidney transplant patients and how do we collaborate with BC Transplant on ensuring that those patients who need it receive nutritional supplements in a timely way. So I'll just go into the BC Nutritional Supplement Policy. Essentially, this policy has specific criteria that a patient needs to meet in order to qualify for a nutrition supplement. The nutrition supplements, they're moving forward, are covered 100% through BC Renal, and they are controlled entirely through prescriptions from a registered dietitian. So a registered dietitian is the steward of this program. Again, I want to highlight how unique and incredible this opportunity is to have this program. So if a patient presents with less than 10% weight loss, greater than 10% weight loss over a 6-month period, if their current weight is under the desirable weight calculation, and if their dietary intake is suboptimal, and this is a key feature of when we would maybe initiate supplements for someone, is if they're not eating well, because it's kind of that beginning of the cascade. And so it's we find that it's a preventative time to intervene, prevent further weight loss and muscle mass loss. Or if they've had a hypercatabolic state, of course, if they're post-op, they've had any type of health issue that's affected their the catabolic rate. So patients who meet the criteria for malnutrition are reviewed for tolerance and suitability of the oral nutrition supplement. In fact, we do have a number of patients who do not continue with supplements because of tolerance issues or allergies. So some of our patients who would benefit from supplements can't actually take them. As I mentioned, the dietitian is the sole provider who can fill a prescription, and we have partnering pharmacies with whom we liaise on sending the prescriptions out for delivery. We've noticed with our research that there has been a standard percentage of ordering patterns, so it's just about 10% or slightly less, and Michelle will go through those details. But it really does show this consistent 10% practice over the years. So it's not a program where we just, I would say, willy-nilly order supplements for patients. We're controlling it tightly so that the rates of prescriptions are kept consistent over time. We do have variations in prescription patterns. So this is something we want to really look at and explore. And what this research has highlighted is the importance of this unique model to allow universal access of supplements to patients who need it. Moving forward, and this is why I feel so excited and empowered to participate in this research, is because, you know, we're frontline workers and we really want to put into practice some of this, academic work that is happening. And so that's kind of where I feel I come in, and my dietitians committee comes in, to helping us better understand how can we help patients and how can we help the system stay and remain sustainable. So we just really would like to know, we have this supplement program, what is the demographic of our patient population? Where are the gaps in our prescription patterns? And are we actually able to be as cost effective as possible to allow this program's sustainability? Do we have the right formulas on our formulary based on our patient needs? Has the landscape of health changed that we need to change our supplements accordingly? Are there patients that we are not even able to reach, and how can we create better access and better reach? And also, are there biochemical metrics that we can use in order to have a proxy for malnutrition in the absence of some data such as food frequency questionnaires and a thorough subjective global assessment? So I'm excited to continue to answer these questions as we work together. Thank you.
Great, thank you, Dani. So I'm going to be going through our research findings. So first of all, our research program objectives were threefold. First, to describe nutritional status among patients with chronic kidney disease, and I'm going to focus on the non-dialysis population for today's session. Secondly, to assess oral nutritional supplement prescription patterns and their regional variation. And thirdly, to assess the association between oral nutritional supplements and outcomes, and this includes nutritional parameters as well as patient-reported symptom burden. So in terms of our study design, it was a cohort study utilizing PROMIS registry data. We looked at adults with non-dialysis CKD followed at kidney care clinics, and we excluded patients with previous renal transplant. Our descriptive analysis used a cohort that entered the kidney care clinic between 2013 to 2018, and then our outcomes analyses used a cohort that were followed during 2010 to 2019 in KCC. In terms of the measurements that we selected from the PROMIS database, we have the demographics listed on the left, and on the right side are nutrition-related variables. In red, we have the 5 variables that we focused specifically on. These include body mass index, serum albumin, phosphate, bicarbonate, and neutrophil to lymphocyte ratio. So we don't routinely measure specific inflammation markers, but we do have the complete blood count. So we can calculate the neutrophil to lymphocyte ratio, also called NLR. And it is a measure of inflammation. A value of more than 3.5 has been associated with elevations in other inflammation markers in kidney patients. And I just want to note that we don't have electronic capture of dietary intake, even though the dietitians do, they do perform dietary intake assessments. And we also do not have muscle mass data in the PROMIS database. And just an overview of the results, and just as a reminder, when I refer to ONS, I mean oral nutritional supplements. So first of all, we're going to go through the nutritional status, including a cluster analysis that we performed, and then on to oral nutritional supplement prescription patterns, including longitudinal patterns and assessment of regional variation. And then thirdly, we're going to look at the association between supplements and outcomes. So first of all, in terms of the characteristics of patients taking oral nutritional supplements, in our entire cohort, we have 15,859 patients, of which 9% were prescribed oral nutritional supplements within the first year of the kidney care clinic follow-up. The baseline variables are listed here, and in the green, you see the variables that are significantly higher in the ONS group, and in the red, you see the variables that are lower in the ONS group. These differences were quite subtle, but statistically significant because we have a very large sample size. The key differences that I'd like to highlight are in yellow, and they are a lower eGFR and a lower BMI among the patients receiving ONS compared to patients who did not receive ONS. And so our first question was to assess if there was heterogeneity among these patients' prescribed supplements. And to answer this question, we use a cluster analysis, which is a form of unsupervised machine learning. And the goal is essentially to create distinct groupings based on their similarity across multiple variables. So we selected 5 nutritional and inflammation parameters, BMI, albumin, phosphate, bicarbonate, and the neutrophil to lymphocyte ratio. I'm not going to discuss the details, but there is a method of obtaining an optimal number of clusters, and the analysis is an iterative process. So in this cohort of patients with baseline data, 5 clusters were identified. And for each variable, the cluster with the lowest mean is in red, so these 5 columns on the right. And then the cluster with the highest mean is indicated in blue. And then we labeled these clusters according to their most prominent features. So for example, in cluster 1, it has the highest NLR of 13.4. and it was labeled as inflammation. In cluster 2, it had the lowest mean albumin, and we labeled it hypoalbuminemia. Cluster 3 had the lowest BMI. Cluster 4 had the highest BMI, and all the other parameters were within normal range. It's likely that this group of patients has sarcopenic obesity that have low muscle mass despite high adiposity. And then cluster 5 had the lowest mean bicarbonate, and we labeled this group as acidosis. So the implication is that patients prescribed ONS are heterogeneous with different features of the protein energy wasting syndrome. And different clusters could have different responses to nutritional interventions, and this can help to inform subgroup analyses by cluster. Okay, and now on to the ONS prescription patterns. So our first aim was to look at the longitudinal patterns over 3 years. We used a Sankey plot to look at this. And our second aim was to assess the regional variation through a logistic regression. And we looked at this by health authority and by number of dietitians in each health authority. And we adjusted for patient characteristics, including nutritional status. So in the longitudinal analysis of ONS prescription patterns in the overall cohort, we see that ONS use in the first, second, and third year of clinic follow-up remained quite stable between 8 to 8.9% of patients. And during the second and third year of follow-up, ONS users were comprised of approximately 40% new users and 60% previous users. So this is the Sankey plot here showing longitudinal ONS prescription patterns among patients who received an ONS prescription in the first year of follow-up. So most patients were prescribed ONS infrequently with 1 to 2 prescriptions per year. And about 25% of these patients stopped ONS in the subsequent year. And in the green boxes above here, we see that these are regular users. They have 3 or more ONS prescriptions per year. And many of them maintained this pattern of use in subsequent years. And we have a significant proportion of patients who discontinued follow-up due to dialysis, death, transplant, or discharge from the clinic. And I note that most of the patients were on general oral nutritional supplements and just a small minority taking protein supplements. Okay, and we found regional variation in oral nutritional supplement prescriptions by health authority. So this ranged between 7.1% to 10.5% of patients between health authorities. So if we have Vancouver at the top as the reference, the Interior Health Region had no difference compared to the Vancouver. And the Fraser and Island Health Authorities had greater odds of oral nutritional supplement prescription compared to Vancouver. And the Northern Health Authority had significantly lower odds of ONS prescription with an odds ratio of 0.51. And this was adjusted for patient characteristics and nutritional status. And to assess for possible causes of this regional variation, we assessed the number of dietitians in each health authority, which ranged from 0.7 to 2.12 dietitian full-time equivalents per 1,000 CKD patients. And so there was regional variation in dietitian resources. And adjusting for patient characteristics, there was a positive association between number of dietitians and oral nutritional supplement prescription. So every 1 dietitian full-time equivalent was associated with a 32% greater odds of ONS prescription. And so this may partially explain the regional variation. Okay, and now I'm going to go through the association between oral nutritional supplements and outcomes. Firstly, using longitudinal data, we were able to look at nutritional parameter slopes. And so we did a pre-post analysis comparing the 2-year slopes before and 2 years after the first ONS prescription. And we use those same 5 key variables: BMI, albumin, phosphate, bicarbonate, and the neutrophil to lymphocyte ratio. And we did a linear mixed effects model with segmented regression, and adjusted for patient demographics as well as the calendar year of ONS prescription. So the graphs here are showing the fixed effects here for the slopes, and this is the BMI trajectory. So time 0 is the time of the first ONS prescription, and to the left is the pre-ONS period, and to the right is the post-ONS period. So the pre-ONS slope is indicated by a blue line indicating a declining trajectory, and the orange line is the post-ONS, which shows a positive slope. So the change in the slope from post to pre was an increase of 0.91 kilograms per meter square per year. And so this is the slopes for the albumin, and ONS was associated with an increase of 0.82 grams per liter per year slope with ONS prescription. And ONS was associated with a decrease in the neutrophil to lymphocyte ratio slope by 0.55 per year. This is a favorable change. And oral nutritional supplement prescription is associated with a slight rise in the phosphate slope by 0.02 millimoles per liter per year. It was statistically significant, but of small magnitude. However, ONS was not associated with a change in bicarbonate slope. So the slope shows a decline of about 0.5 millimoles per liter per year, and this was unchanged with oral nutritional supplement prescription. So among patients who had a longitudinal data, we did a cluster analysis again, similar to the process I described earlier. And again, we identified 5 clusters. For each variable, the lowest mean is in red and the highest mean is in blue. For each of those 5 variables in these columns on the right. And so cluster 1 had the lowest BMI and the highest NLR. Cluster 2, hypoalbuminemia, lowest albumin. Cluster 3 had a low BMI, but not the lowest among the clusters. Cluster 4 had the lowest bicarbonate, and we call this acidosis. Cluster 5 had the highest BMI. And so we used these clusters to look at their trajectories to see if there was heterogeneity in their responses in those nutritional variables. And just for illustration purposes, I'm going to show you cluster 1 and cluster 2 trajectories. So we see here that there was a statistically significant increase in albumin, bicarbonate, and BMI slopes, and there was a significant decrease in the NLR slope for cluster 1, which this group had the lowest BMI and the highest neutrophil to lymphocyte ratio. And we contrast this to cluster 2. There was a statistically significant increase in the albumin, phosphate, and BMI slopes, but no significant change in the neutrophil to lymphocyte ratio or the bicarbonate. So the implications of this cluster analysis are that it allows us to identify phenotypes by integrating multiple variables. It has applications to omics data in which we would have a vast number of variables to work with. And secondly, our example illustrates differential responses by cluster phenotype in nutritional parameter trajectories after ONS prescription. And this helps us to explain heterogeneity in response to dietary interventions. And thirdly, aligned with the concept of precision nutrition, this allows us to consider personalized management and follow-up after identifying phenotypes. Okay, and the last outcome we'll discuss today is symptom burden. So the Edmonton Symptom Assessment System is a quantitative symptom assessment battery. It's been adapted for use in the renal setting, and there are 12 symptoms as listed here, plus the patient can add a 13th symptom if they wish. A higher score represents worse symptoms. And this ESAS is routinely assessed in patients with eGFR less than 15 in BC. So our first question was to ask, is nutritional status associated with patient-reported symptom burden? And on this graph, or this figure here, is a directed acyclic graph. And we did an exploratory linear regression analysis to assess if there was an association between these 5 nutritional variables listed on the left with the outcome of wellness, tiredness, nausea, and appetite. And these are subscores of the ESAS that we hypothesized might be affected by nutritional status. And we adjusted for possible confounders. So the results of this multivariable linear regression are shown here. Keeping in mind that lower ESAS score reflects lower symptom severity, we found that higher serum bicarbonate was associated with lower nausea and appetite scores, as indicated by the orange diamonds here. However, other variables did not show any statistically significant associations other than increased BMI being associated with increased tiredness scores. And next, we wish to determine if oral nutritional supplement treatment was associated with a change in symptom burden. So we assessed a cohort of patients with at least 2 ESAS assessments. Because there is strong confounding by indication, we address this through propensity score matching in order to make sure that we were comparing similar patients who received oral nutritional supplements versus those that did not receive oral nutritional supplements. So we use those confounders at baseline in order to match patients to build the propensity score. And once we matched patients, we had similar patient characteristics among the 156 pairs that were analyzed. So in our linear regression, we did not find a statistically significant association between oral nutritional supplement prescription and change in ESAS. And so we see here the overall score as well as appetite, nausea, and tiredness. Some associations were positive, some were negative, but the 95% confidence interval did cross 0 for each of these parameters. And there are a few possible explanations. First of all, oral nutritional supplements may not affect these symptom parameters in this population. And secondly, the ESAS outcome may not be a sensitive indicator of patient symptoms associated with nutritional status. So just to quickly summarize the results that I've shown you, at baseline, we know that patients prescribed oral nutritional supplements had lower eGFR and lower BMI and more metabolic complications of CKD. In terms of prescription patterns, about 9% of patients received ONS within the first year of KCC follow-up. Most had infrequent prescriptions, and there was variation by health region in BC, which may partially be mediated by number of dietitians in each health authority. And we know that looking back at the trajectories that we graphed out, having at least one ONS prescription was associated with improvements in BMI, albumin, and NLR slopes with minimal changes in phosphate and bicarbonate. And our cluster analyses that we did demonstrated different phenotypes of protein energy wasting and heterogeneity in response to ONS. And then in terms of the symptom burden outcomes, we didn't find a statistically significant association between ONS prescription and change in ESAS scores, but there may be associations between bicarbonate and nausea and appetite symptoms. So in terms of strengths of our study, this is the first study to assess the effectiveness of ONS in the treatment of protein energy wasting in non-dialysis CKD. And we have a unique setting in BC where we have a province-wide registry, longitudinal data, and standardized protocols and policies, as well as an oral nutritional supplement program that is makes it available without cost to patients. And in terms of our limitations, this is an observational study, so we can't infer causal effects, and residual confounding is still possible. For the pre-post analysis, there were possible secular effects, but we did adjust for calendar year. And thirdly, we did not have electronically captured dietary intake or muscle mass or subjective global assessment scores. However, we did practice, or we did focus on practicality, what's used in normal practice in terms of readily available objective variables. And so there are a lot of knowledge translation and implementation goals. This program is a model for research collaboration between nephrologists and allied health. And through the ISN Emerging Leaders Program, my goal is to develop strategies to build this research capacity. And secondly, there's a lot of implications for informing policy. We can revise the nutritional supplement policy based on our results of research. This will also help us to plan for resource allocation for dietitians across the province, and also help us with quality improvement initiatives to improve the standardization of care. And there are lots of knowledge translation avenues, including presentations, publications, and abstracts. And this will hopefully facilitate future research, and we're hoping to improve electronic capture of dietitian assessments in this regard. For future directions, in terms of reviewing the ONS policy, we can add biochemical parameters potentially to complement the weight and dietary intake criteria that are currently used for determining ONS prescription. And this may be especially helpful in the era of increased telemedicine care. And secondly, we will possibly do a qualitative study to further look at the causes of variation in ONS prescription. And this may involve interviews or focus groups with the dietitians. And thirdly, we'll extend these analyses to the hemodialysis and peritoneal dialysis population. I just want to acknowledge the research team, especially Sophia Zhang, who performed the analyses that were shown today. And I'm happy to take any questions.
Thanks, Michelle, and thanks, Dani. So one of, and I think, you know, it's an excellent example of both collaboration, but also things that are relevant to our population and a better understanding. There are some questions. I'll remind everyone to put more questions in the Q&A. So there were, one question was, do you think that some of the results of the improvement is a combination of both ONS and the fact that there's dietitian support? Is there a way to tease out that, or is that something that you can look at?
Yeah. So I think it is a little bit hard to tease that out. All patients are provided the dietitian care, and if they meet criteria for the oral nutritional supplements, then they're prescribed it. But I think it's really assumed that it's sort of a combination of the intervention is the dietitian care with the oral nutritional supplements.
And I think one thing that really stands out, having gone through this process, is the need for very tailored and individualized care for patients, because there are obviously unique factors within everyone's nutritional pattern. and lifestyle and all these other external factors outside of their nutrition status that impact, directly nutrition status. So I think being a dietitian, going through the questions with each individual, there are nuances that would be great to look at and see if they're, even in a qualitative way, what are some of the themes that emerge from these interactions that we have with patients. And I would also say that since some of us have gone more virtual, that has deepened a great deal. So I think this is a really interesting question, and I certainly do think there's some weight to it.
No pun intended. That was so good, Dani. One of the questions was, does anything in this, anything in the analysis or the results surprise you? Like, was there something that surprised you when you looked at the information?
Do you want to go ahead, Michelle, or?
Yeah. So yeah, I think that's an interesting question. I think that originally I thought that longitudinally there would be increase in the number of ONS prescriptions over time as people's kidney function would decline and they would develop more complications of CKD. So the fact that we saw a very consistent percentage of patients prescribed ONS over time was a bit surprising, but I think it makes sense that the dietitians are stewarding the program in a very responsible way, and we also have a significant proportion of patients who leave the kidney care clinic as well. So overall, the use is very stable. And I think the other thing was looking at the cluster analysis and looking at the different trajectories, the different responses. So I think the first cluster that we looked at had low BMI and high inflammation, so high NLR. So they appeared to respond very well to oral nutritional supplements. So I think it is interesting to look at the different clusters. The most common phenotype, though, is still hypoalbuminemia. So I think the cluster analysis is very useful because protein energy wasting is so complex, and you have all these different features of the syndrome. So just looking at their differences and their different responses has a lot of implications, perhaps, in how we treat these patients.
Yeah, and I think part of this may be also a bit self-fulfilling, right? So hypoalbuminemia is one of the triggers for dietitians to actually intervene. I think I must say that the most fascinating thing that I found was these clusters, like that you found, was these clusters that I found interesting, because I think it does help us. The more that we understand chronic kidney diseases, the more we understand the heterogeneity of the population that we have, and one size doesn't fit all, then I think it makes this nuancing better. And then, as Dani pointed out, as we're going more virtual, the notion that we could even measure body mass index properly, or muscle mass, etc. So if we do have these nice parameters that help us, then that may be very useful. So I think, you've uncovered or unearthed, so to speak, some really interesting concepts that I think we could put into play and are quite novel. So, really congratulations on that thoughtfulness. Are there other questions? You got a huge group of people, including some patient partners, dietitians, and physicians on the line watching. So that's really terrific, and obviously a huge interest. Diet impacts so much of our lives, and how we help people address it is important. There's another question. Was it assumed that those on ONS were also prescribed high-calorie diet, and were patients instructed to modify diet to increase calorie nutrition density? Was that something that you did? That sounds like a good question for Dani.
Yeah, so thanks for the question. I think this is not something I could answer universally. I would say when I'm practicing, I tend to, obviously encourage people to eat food first. And I think that's kind of the culture of nutrition counseling is that you try to help people achieve their needs through food first, and then the supplement is literally a supplement, right? So it's kind of an adjunct to having a more appropriate, even nutritionally dense diet, as you point out. So yeah, I think more or less we would do that in our practice, and we do always take, you know, a 24-hour recall to see where the gaps might lie. So it would be a combination. And that's probably why some of this is kind of nuanced again.
I think it's also probably fair to say that, you know, especially in non-dialysis patients, diet's the one thing that people have control over. And as you have a chronic disease and lose control over things, making sure that there is that aspect of self-management, self-control is probably important, both psychologically as well as physically. So I think you're right. It's not as simple, we'll do this and this will happen. I'm trying to manage the chat box at the same time and the Q&A at the same time. So it's okay, we only have 4 minutes left. So I want to really thank Michelle and Dani and the entire stats team for really thoughtful, both questions as well as analyses, as well as putting together a really informative overview of the state of nutrition, the use of ONS, prescription and dietary counseling within the province of BC, and really an example of not just collaboration for research, but collaboration to really inform care and give us more questions to ask and answer so that we can actually improve outcomes. So thank you so much for the preparation, and thanks all of you for listening, and we will get all the feedback. So thanks very much.